because it's kind of a routine technique in many hospitals as well as in ours. And the tricuspid valve repair is not that far yet. It's still a bailout technique, although data have been increasing about practicability, and I will talk a little bit about that. To start with, I will talk about the course of the mitral regurgitation. You all know this is an old slide from Enrique Serrano that depending on the amount of EROR, the amount of MR, the mortality increases in asymptomatic MR, and that doesn't distinguish between the origin of the MR, whether it is a functional or a structural one. This is the reason why the European Society of Cardiology guidelines already in 2017 have increased or included the repair of a relevant MR as a high recommendation. And already in this guideline, the edge-to-edge repair using the mitral clip, or nowadays also possible using the Pascal method, I'll come to that later, has been included whenever the surgical method is not feasible. Now, the systems that are used basically are the mitral clip and the Edwards system, which is called the Pascal device, which has come out with some features that were improved in comparison to the first mitral clip, but the first mitral clip also has improved, and it has now 4 different shapes. The original shape, which was called the NT shape, then a little bit wider shape, which is now called the NTW shape, and then there's a large clip, the XT and the XTW clip. And another feature that this clip now also has is what the Pascal device already had for a long time, that you can selectively use the so-called grippers, with which you grasp the leaflets. So leaflet grasping in some tricking anatomies can be difficult, and that was a feature that was supposed to be improving the possibility of leaflet grasping, so one could grasp one leaflet first and then carefully move to the other leaflet and grasp it later. It's not very much used, but sometimes it can be of advantage. Of course, there are other systems. There are for repairing transcatheter repair of the mitral valve, for example, the Carillion system, which is an indirect annuloplasty system, or the Cardioband or the Mitraline. These systems are selectively used in Germany in large valvular centers, whereas the mitral clip and the Pascal device, the edge-to-edge repair, has been spread to mid-sized clinics as well. So what is the study line for the large mitral clip studies? The mitral clip is the only device that actually has large clinical trials which have brought up results. And in general, one will compare a functional MR, which is due to annulus dilatation or LV dysfunction and general dilatation of the heart, from a primary MR, as seen here with this prolapse of the posterior leaflet. The primary MR and the secondary MR in the initial study, which was the mitral clip Everest 2 trial, were initially not really differentiated before inclusion in the trial. However, the trial did differentiate how many were functional and how many were degenerative MR. So in this large trial, there was the first evidence that when using this mixed population of MRs, patients can actually profit in terms of freedom from worsening MR mitral valve dysfunction or death in comparison to the surgical method. There was no improvement in mortality, and there was no improvement in MR in comparison to the surgery. So it was more or less a equality outcome, that it can be equal to the surgical method. But I must say that the majority of patients in these studies were degenerative MRs, which whenever patients can be operated, should be corrected surgically. Now, the later coming studies, which I'll now present, the MITRA-FR study and the COAPT study, used a more realistic patient group, which were mainly the functional MRs, which is the group that are very much treated today, because the surgical data for these patients are not very good. The second of these published studies was the MITRA-FR study, and it has some backtracks, especially that the operators who did the implantations were surgeons. They had only 5 training procedures before starting, and then they included the patients which were NIHA class 2 to 4, had a low ejection fraction, but did not have optimal medical treatment or even CRT on a regular basis before they were included. So basically, functional patients were treated before the indication was really good, because the optimal medical therapy and the CRT, which we today think is absolutely necessary if there's an indication for it, should have been corrected first. And this study did not bring any result. There was no advantage in the control group, which in comparison to the intervention group. So from the MITRA-FR study, there have been brought about many questions whether the MitraClip is of any use at all. Another study, which was published just weeks before the MITRA-FR study, was the COAPT trial. The COAPT trial was very, in my opinion, very well-designed trial. It was in 78 centers in US and Canada. It was only functional MR patients, which were also randomized to optimal medical treatment in comparison to the MitraClip. These patients had to have CRT before MR was assessed if CRT was indicated, and they had to have optimal medical treatment. And then they were randomized. There was no crossover, and the experience of the implantators was at least a mediocre experience. So it was centers that had used the MitraClip before in the majority. And in this study, there was a nice benefit in terms of the primary endpoint, which was a combined endpoint of hospitalization and heart failure. And this was mainly due to fewer hospitalizations, but it was also had a nice signal in terms of death from any cause. So it's necessary to compare the readout from those studies a bit. As I said, the Everest 2 trial included different patients. Many of those were degenerative, some were functional, and it was a comparison of MitraClip versus surgery. In the MITRA-FR and the COAPT trial, there were only functional patients, and the outcome, the main result, was very different in terms that the MITRA-FR trial did not show any benefit, whereas the COAPT trial did show less heart failure, rehospitalizations, and lower mortality with the MitraClip at 24 months. There were differences in study design. There was low experience in the MITRA-FR trial and moderate experience in the COAPT trial, and some of the complications which were not even reported in the MITRA-FR trials, and other complications like, for example, bleeding complications, which I think can be a big backdraw if the procedure is not done in a very controlled manner, were high in the MITRA-FR trial. And this is also in comparison to the large registers, the TRAMI and the Access EU register, where many patients have been treated nowadays. And in these registers, the operator experience is very high, and the procedural success rates are also very high. And then the complication rates are very much lower in comparison to the randomized trials. So let's talk about a little bit about patients that we should select. There are challenging or even unsuitable anatomies, like for example, when the posterior leaflet is very short, so you can hardly grasp the device. This is due to, especially at this site where the MR is originating, very short leaflet. These patients in many cases cannot be operated or intervened in a perfect manner. There's patient anatomies, for example, when there's mitral stenosis going along with the insufficiency, the regurgitations, where a edge-to-edge method should be avoided. And there are very challenging anatomies, like, for example, this so-called morbus Barlow, which is basically a prolapse of every segment, here accompanied with a little flail in the posterior leaflet, or patients where there is a very eccentric gap, which needs to be corrected here in the P3, A3 leaflet portion. These patients may be corrected with an edge-to-edge method, but it's much harder than a classical functional MR where you want to grasp in the A2, P2 region. And then there's the complications. I think it's very important if you do such a controlled method to avoid complications. So we have to look at what the major complications are. These are bleeding complications, and those are among the specific complications, it's the single leaflet clip detachment complications. I must say that these data all were obtained with the normal mitral clip, and now the generation 4 mitral clip has many features that allow us to avoid at least the single leaflet detachment complications. Let's look at how this may end if you have single leaflet detachment. This may end in a rocking clip, which stands awkwardly and causes an enormous new MR, because the clip may rock against the posterior leaflet as shown here, and it can be in this case corrected if by implantation of another clip. There's a very awkward complication which we've experienced sometimes, and I would like to show it. There are patients which have pulmonary hypertension independent of MR. If you implant the clip in these patients, we have sometimes seen a sudden drop in oxygen saturation upon removal of the implantation sheets due to a right to left shunt. And in these patients, it may even be necessary to acutely close the iatrogenic ASD, as has done here, and this will result in an immediate return to good oxygenation. So this is something one can observe, and these are just some examples to make sure what you need to keep in mind if you want to start a mitral clip repair program. Now let's summarize the interventional MR repair. The MR is a heterogeneous condition with several etiologies and anatomic variation. The echo is the most important feature to assess if the MR is primary or due to LV dysfunction and annulus dilation. The edge-to-edge mitral valve repair mimics surgery by creating a double orifice valve, as you all know. There are other methods as the annuloplasty devices, which may address the problem, and in some situations may even be methods which can be used in combination in very dilated annuli. The experience, the imaging and device improvements all allow for improving results of MV edge-to-edge repair over the years. So not that of today, I would like to say that in the right patient, edge-to-edge mitral regurgitation repair is a very safe and effective method in the hands of an experienced operator using the novel devices. These are the MitraClip G4 Generation 4 system and the Pascal system, because they allow us to overcome some of the concurrent anatomical limitations of edge-to-edge repair. And for all the other systems, the clinical outcome data are limited, and they, at least to my knowledge, and they are most often used in situations where the edge-to-edge method is not feasible and surgery is not an option. Now let's talk about the tricuspid valve. It has been called the forgotten valve because there has never been a real good method to correct it, neither surgery nor medications. And we all know from our experience that the etiology of a tricuspid regurgitation is most often secondary to other heart or valvular diseases, and also does not have a very typical symptom combination. Now, often it is due to increased pulmonary artery pressure due to left heart disease or PA hypertension. And this has to be distinguished from a primary tricuspid regurgitation due to diseased valvular apparatus, or to a dilation of the right heart chambers, which then can be called the functional or even the primary tricuspid regurgitation. Now we know from operated patients, these are patients which had been surgically corrected in the mitral valve, and it was during the post-operative course observed what the influence of the remaining TR would be on the probability of survival. And we know that the severity of TR is a major factor in survival in these patients. Now, the pathophysiology, as I said, is due to RA or RV volume overload, tricuspid ring dilation, and this all may lead to a worsening of TR, go along with atrial fibrillation and RV pump failure. As I said, the symptoms are not quite as obvious as with MR, where you have a symptom of basically cardiac failure or cardiac congestion. In TR, it is more a combination of worsening of general condition, often very, very sick patient with generalized edema, ascites, liver congestion, rise in hepatic enzymes, or even cirrhosis cardiac. You can see the jugular vein pulse, and they are sleepy and very sick. Now, from the first years of effort to improve the TR by non-invasive or minimally invasive methods, the societies have come up with a more distinct grading of the severity of TR. We now say there are 5 grades of TR, and they can be lined with 5 stages, 5 clinical stages. And we have learned that the most impressive, the torrential TR, may not be something that can be corrected very well. Even the massive TR often cannot be corrected very well by an edge-to-edge method. When we come back to the surgical guidelines, it's quite clear that the primary TR should be operated on if the patient is surgically or feasible for a surgical procedure, whereas the secondary TR has a recommendation for being reconstructed when the patient is undergoing left-sided surgery in any way, but not when there is pulmonary hypertension or only a moderate TR. And these recommendations may differ from the future of tricuspid repair by an edge-to-edge methods. Now, there are many different interventional repair methods. Of course, there are the surgical methods. Then there is a large number of procedures for the direct ring annuloplasty, and there are the edge-to-edge methods using the MitraClip. Now, Abbott has come up with the Tricuspid or even the Pascal device. there has been, still been used the so-called FORMA method, where a spacer is introduced in order to reduce regurgitation orifice. And of course, there is interventional or mini procedures, mini surgical procedures where there are direct valve replacements, either by cardiologists alone or in a hybrid procedure. I will today only talk about the TriClip device. It's similar to the MitraClip device, but has been designed specifically for the different anatomy coming to the tricuspid valve, because you don't need to do a left atrial septum puncture, and you have different angles at the top of the clip. But the steering is quite similar, and the device setup is also similar to the MitraClip device. Now, these are nice images from a presentation by Jörg Hausleitner, which show a transgastric view of the TR by TOE. And we can see that the three leaflets may all differently be affected by the TR. And there has been a lot of discussion what the strategy for the repair should be. Most patients which are treated nowadays are been treated by a strategy as outlined in this paper by Jörg Hausleitner today, where either the anterior septal leaflet or the posterior septal leaflet are being grasped, and the aim is a bicuspidization of the tricuspid valve. This has been evaluated in the Triluminate study. It's a single-arm study without a comparison group, a feasibility study, which has been published this year in the Journal of the American College of Cardiology. And it has shown that in the hands of these experienced operators, the major adverse events in those very sick patients are acceptable. 85 patients have been included, and the 1 year outcome in terms of the reduction of hospitalizations compared to the year before the patients were treated is promising. Also, the procedural result is promising, as the durability of the repair seems to be stable in at least a relevant group of patients. But also from the study, we can see that this is a much more complex procedure than the mitral valve edge-to-edge repair, due to the different anatomy of the right ventricle, to the different anatomy of the tricuspid valve, and also due to the different pathophysiology underlying the tricuspid regurgitation. We know from another study also being initiated or participated here in Munich, which compared whether it is of advantage to do an interventional concomitant MR-TR repair by the MitraClip in this case. And we know from the study that those patients who had severe regurgitation profited if it was concomitantly corrected with the severe MR. But altogether, there are no randomized large clinical studies. And so tricuspid regurgitation repair by the edge-to-edge method still remains a bailout experimental procedure in patient where optimal medical treatment does not lead to a relevant improvement of symptoms. We know a bit about the ideal patient for this method. It should not be a too heavy TR. The pulmonary artery pressure should not be too high. It is not of any favor if the TR is induced by pacemaker leads, and if the coabdation defect is not too large, it is easier to grasp and correct the TR. So altogether, it must be said that with tricuspid valve repair using a transcatheter method, most patients they suffer from end-stage heart failure, and it's a bailout procedure for those patients with severe comorbidities which are not eligible for any surgical method. The clinical benefit is still unclear, but there is evidence from the TRILUMINATE study that there may be an improvement in systems, but it has only been symptoms, but it has only been a single-arm study without comparison. The outcomes are hard to assess. The echocardiographic features or the improvement is a bit easier to assess. There will be a clear path to the patient selection. It's the key to the procedure. And we are awkwardly waiting for more data for randomized studies, which include patients which were treated by the method in comparison to optimal